Dr. Oleo Carolyne. She's a seasoned gynecologist working with Kyabirwa Surgical Center as a women specialist. Before we proceed, we are going to have a brief prayer, opening prayer by a volunteer. Can someone pray for us? Hello. I need a volunteer to pray for us. Unmute and pray.
Good evening, how are you? Okay, let's pray.
Yes, Noah.
Yes, loving and heavenly Father, we want to thank you for this evening. We want to thank you for the presenter. And we want to thank you for the members that are on this platform. Father, as we are going to share the knowledge, we pray that you use the person who is going to present to us and ask the participants, may we use this knowledge to impact on the lives of our clients. Through Jesus Christ, I pray. Amen.
Thank you, Noah, for that brief prayer. As I've already been introduced, I'm Dr. Chizala Susan Nyende, Obs and Gyn, working with Kamuli General Hospital, and I'll be your moderator for tonight. Before we invite our presenter for the day, we are going to have a brief overview of Busoga Health Forum. I hope all members on the chat are subscriber members. If you are not, you're encouraged to subscribe. Busoga Health Forum is an association of like-minded people and professionals stimulating community. Sorry. I'm using my phone. Busoga Health Forum is an association of like-minded people and professionals stimulating the community, government, and partner actions for better health of the people. We are a national, not-for-profit, voluntary membership-based organization with its headquarters in Jinja City. BHF works in collaboration with the Ministry of Health, local governments, and civil society organizations to coordinate health interventions through established technical working groups and technical administrative structures, including district health teams and formal or non-formal community structures. BHF is therefore a think tank generating evidence to drive health policy to improve the health and development of individuals in Busoga region and beyond. Next slide. Our vision is a healthy, thriving Busoga. Next slide. Our mission is to rally Busoga professionals to use evidence to engage community, government, and partner action for better health of children, youth, women, and men in Busoga region. Our core values are value addition, collaboration and integration, impact focus, transparency and accountability, effectiveness and efficiency. Our core program areas include reproductive, maternal, newborn child and adolescent health, that is ROMNAC, malaria, HIV and TB, regional planning and data use, infectious and non-communicable diseases, and urban health. That's our website. In case you want to find out more details about Busoga Health Forum, you can go to our website. You have seen it. And if you want to be a part of the efforts of Busoga Health Forum to improve the health in Busoga, you can join. Subscription fee is 100,000 for individuals and 500,000 for institutions. Lifetime membership is 1 million shillings, but you can pay in installments if you don't have the 1 million at a go. So members, I hope you have all been interested to join BHF. Yes, the vision was for Busoga region, but we work beyond Busoga. So you can join from wherever you are. For as long as you have a heart for Busoga region, you want to improve community health, you're most welcome to join. You can also provide technical expertise. You can join, and if you have good presentations or CMEs, you can contribute to anything financially, CME presentations, community awareness campaigns, or even providing technical support in case they have campaigns. So members, you're all welcome. I think we have enough quorum to start. Members, can we start? Hello?
Yes, Doctor, this is very enough. We can start.
We can start. Okay. So allow me to introduce Dr. Carolyne Oleo, an alumni. She was my alumni and has been working for over 7 years as an obstetrician and gynecologist. Currently working with Kyabirwa Surgical Center as a women health specialist. Dr. Carolyne Oleo, you are very welcome to Busoga Health Forum, and you can take it on from here. You're welcome, Carol. Kindly unmute.
Thank you, Dr. Susan, for the introduction. Hello, everyone. I'm happy to be here today, and I'm really happy to be associated with the Busoga Health Forum. As Dr. Susan has introduced, I'm called Carolyne Oleo, and I am the women's health specialist working in Kyabirwa Surgical Center. Today, coming in to look at benign ovarian masses in Premenopausal. And by the end of just a minute, let me just put this on slide share. Okay. So our topic for today is benign ovarian masses in premenopausal women. And we are going to have the definition. We're going to set the rationale why we are looking at this topic today. We shall briefly look at prevalence of benign ovarian masses. We shall look at the different types of benign ovarian masses. This is basically looking at the differentials. We shall look at the clinical presentation, the diagnostic approach, and then we shall end with the management. So it's not a very detailed presentation. It's a bit short and summarized. So benign ovarian masses simply mean non-cancerous masses on the ovary. And then premenopause simply means the period preceding the period before menopause. So these are usually women who are in their reproductive years. They are still experiencing their menstrual periods and they do not have any symptoms of perimenopause or menopause. So in short, these are non-cancerous growths in women who are still in their reproductive stage or reproductive age, or women who are not yet in menopause. So the question you ask is, so what? And this is because of the challenges that we face in the management of ovarian masses in this age group. Remember, we are looking at ovary and we are looking at a group of women who are in their reproductive years. So there's a mass in the ovary. Yeah, so these are usually women who have fertility desires. They are still conceiving, and sometimes these are women who will present with an. So it usually causes management dilemmas on when to do conservative management, or when to do surgery, or when you proceed to surgery, when to do cystectomy. Cystectomy simply means removing the ovarian cyst or just the mass, or to do simply means to remove the entire ovary. So that is the rationale for this topic. So I would say that the prevalence stated on this slide is not specific to Uganda. It is actually more global. And about 10% of women will have some form of surgery during their lifetime due to the presence of ovarian masses, of an ovarian mass. However, most of the masses in premenopausal women are non-cancerous. And we have an incidence group is less than 1%. So it's actually stated, this is actually global, it's stated that it is 0.1% in the premenopausal group, which means that, of course, most of the masses that they will present with are non-cancerous. This incidence go up, it's noted to go up as with age. So it gets to 0.3% by the age of 50 years, but you can still note that this is still way below 1%. And the incidence of these masses in pregnancy is 0.2 to 2%, but still the malignancy rate is 1% to 6%. So we can see that the malignancy rate is quite low. So this slide is looking at the different types. Make it quite broad, so that it can show us the differentials. For example, if it is not an ovarian mass, then you will see that on the slides there are bullets which are highlighted red. The bullets that are highlighted red are the masses that would only present in a pregnant woman or that are specific to pregnancy. So if we look at the column on the left, these are purely other non-ovarian masses. So mother, a lady presents with a swelling in the lower abdomen. That's what this slide is basically trying to show. So if I start with the ovarian side, this is really they could be fallopian cysts, hemorrhagic cysts, luteoma, adenomas, or a teratoma. And then when we look on the pregnancy, is definitely to pregnancy. But apart from that, it could be tuberculosis, leiomyomas, hydrosalpinges, tubovarian abscesses, as you can see on the list. So that is basically giving us a broad picture of what else could it be if it is not the ovary. So now here I will slow down a bit because this one is looking at a little more detail. Just for our understanding. So follicular cysts are cysts that form because ovulation did not take place, meaning that usually these cysts are on one side, usually 5 centimeters, and on ultrasound they are seen as unilocular with a smooth surface. They're usually translucent with a thin wall. And then there's also what we call the corpus luteum. Usually this cyst is formed after ovulation, and this cyst is also present in a woman who is not pregnant, and it has a lifespan of around 14 days. However, in case this woman gets pregnant, then this cyst will increase in size, enlarge in size during the first trimester, and it's usually the purpose is to produce progesterone, which supports the pregnancy, and then it regresses into pregnancy. On ultrasound scan, it is also unilocular, it is anechoic, it is smooth, and it is thin-walled. And then we have the fecal lutein cyst. Now this is only specific to pregnancy, and it's usually due to overstimulation from high levels of the hormone HCG, and it's usually present in conditions like PTD or multiple gestation. These ones are usually bilateral, they are anechoic, and they may be usually multiloculated. Then there's what we call the luteinized follicular cyst. The etiology is similar to the fecal lutein cyst, result of HCG stimulation. However, these ones are usually large, they're usually solitary, thin-walled, unilocular, and the mean diameter, which has been noted, is usually 25 centimeters. They're usually very big. Then there's what we call the hemorrhagic cyst. This one's into a cyst, and the example is the corpus luteum cyst. They have a varied appearance on ultrasound scan due to evolution of blood, and usually on ultrasound scan, initially it appears as an ecogenic mass with internal echoes, more ecogenic hypertrophy than the surrounding ovary. However, as the clot matures, it appears as an anechoic gestation that usually resemble a cobweb appearance. And then there's what we call luteinoma. These are specific to pregnancy. They are non-neoplastic proliferations of luteinized cells, and they occur mainly or only during pregnancy. Their growth is self-limiting, and they resolve spontaneously after delivery. Usually, the etiology is also thought to be as a result of hypersensitivity to HCG. Because they are solid, most of the time they are mistaken for malignancy, and approximately 50% of them are bilateral. This particular luteinoma also produce what we call androgens. So both mother and fetus, especially if the fetus is female, may show signs of virilization. And then there's what we call cystadenomas, which is specific to the benign masses. Usually the most common is, and then there's also what we call the mucinous. The serous develop as hyperplastic expansions from epithelial inclusions, and on ultrasound scan, they usually look unilateral in just 20% of cases, and they usually anechoic. And then, to the contrary, the mucinous cystadenomas are unilateral in 90%. So they are mainly unilateral. They are larger in size compared to the serous. They're usually multiloculated, and they have low level internal echoes. Usually they have it is said that they have multiple origins. For example, there are some that are said to originate from germ cell origin, some from surface epithelial origin, and some, probably 58%, as a result of a cross mutation. And then we have what we call the endometriomas. These are usually benign. This is mainly seen in endometriosis, formed by ectopic endometrial tissue. They're usually thick-walled complex cysts with homogeneous low-level internal echoes. Most of the time, patients who have this also have other symptoms of endometriosis. And then, of course, what is quite common, we have the mature teratomas. These are germ cell tumors, usually they are benign, and they contain elements derived from all the three germ layers. They usually comprise 44% of all ovarian neoplasms, and they are bilateral in like 10 to 15% of cases. Usually on ultrasound scan, they appear multicystic with varying content. You may see hair, skin, teeth, or fat on the ultrasound scan. So how do these patients present? I would say many of them who may be asymptomatic, and these masses may be only discovered incidentally when you're doing an ultrasound scan. However, those who present with symptoms will present with pain on the lower abdomen or lower back, or abdominal distension, depending on the size of the mass. There are some people who will present with signs of complications due to these masses. For example, this mass can twist around the blood supply of the ovary, and that is called torsion, or if it is a cyst, it could rupture. And so the symptoms of this complication. So they may present with sudden severe abdominal or pelvic pain, or pain with a fever or vomiting, or with signs of shock. So we are moving on to how to diagnose, or the diagnostic approach to benign ovarian masses. Of course, the gold standard is that the history is usually very important. Detailed history to rule out the possibility of malignancy. And as much as we have seen that the incidence of malignancy is quite low in this age group, it should always be ruled out. We look for risk factors like family history of breast, colon, or ovarian cancer. We look at protective factors against ovarian cancer like breastfeeding, use of COC parity. We look for symptoms of endometriosis, which could probably explain the presence of an endometrioma. During the physical exam, it's very important not to forget to do the abdominal exam and the vaginal exam. On the abdominal exam, it's very important to describe the mass, the size, the location, whether it's tender or not, mobility, consistency. It's very important to look out for lymphadenopathy, that is cervical, supraclavicular, or in the brain. It's very important to do a breast exam. And the purpose of doing a breast exam is because the ovary can be a metastatic site for cancer of the breast. It's also quite important to rule out pelvic infection. And then on the vaginal exam, when you feel cul-de-sac nodularity or shortened uterosacral ligaments, this is usually a sign of endometriosis. Now, in pregnancy, identification of ovarian masses by abdominal or vaginal exam may be difficult, especially after the first trimester, when someone has already, when the uterine volume has increased in size. Some of these masses may be difficult to palpate or to appreciate. So we could look, this slide is looking at the tumor markers and the role they play in the diagnosis of ovarian masses. Now, there's what we call CA125, which is a very common tumor marker that many of us hope. However, it does not need to be undertaken in a it doesn't need to be undertaken in a premenopausal woman with a simple ultrasound scan. So if the ultrasound scan shows may not be important, or it may not change. It is a marker of normal in 50%. It's quite unrealistic. It is also increased in.
Carol, you're breaking. Could you be stabilized, because you're breaking and members are not getting all the points.
Okay. Okay. Can you hear me better now? Can you hear me better? Can I continue?
Please proceed.
So like I said, CA125 is unreliable with increased rate of false positives because it's also noted to be increased in particular conditions like endometriosis. It's also noted to be increased in conditions like adenomyosis. So it means that there's an increased rate of false positives and it has a low specificity. However, if it is done and the values are raised above 200 units per mil, it's very important to consult a gynecologist. Then there's what we call LDH, AFP, and beta HCG. Usually this should be done for all premenopausal women who are less than 40 years, who have a complex ovarian cyst based on ultrasound scan. Now, the role of these tumor markers in pregnancy, I would say that in pregnancy, the CA125, EFP, beta HCG, and LDH are all raised during pregnancy. And CA125 is also raised in certain conditions like preeclampsia, trisomy 21, neurotube defect. So these tumor markers are of no proven clinical benefit during pregnancy because they are already raised as a result of the pregnancy. So for pregnant women, these tumor markers may not be important in the diagnosis for diagnosis purposes, but they may be useful in differentiating primary from secondary tumors for assessing therapeutic response and risk of relapse. So we have the ultrasound scan. This one is very, very common. The preferred is the transvaginal ultrasound scan in assessment of these ovarian masses. It is the first line in distinguishing between benign and malignant masses. It is safe to use with good tumor sensitivity and specificity in defining morphology of pelvic masses, and it's able to evaluate various parameters, the size of the tumor, vascularity, morphology, evaluation of the other side of the anexa, presence of ascites, etc. However, this ultrasound scan also has limitations during pregnancy because assessment of the adnexal region is difficult after 20 weeks of amenorrhea, still due to the increased volume of the uterus, making it hard to really assess or evaluate ovarian masses. And also because Doppler evaluation is less reliable in pregnant women, and yet this is one of the things that is very key in assessment of an ovarian mass to indicate whether it could be malignant or benign. Now, this particular slide is showing us what a normal ovary looks like with zero likelihood of malignancy. So if we look at this, this is just showing us a follicle, which is unilocular, and a point that is less than 3 centimeters. So this is definitely the follicular cyst that we talked about in one of the earlier slides. And this is what it could look, this is what it looks like on the non-ultrasound scan. And this one is showing the corpus luteum cyst, which is usually, when you apply Doppler, you see something like this, what we call a ring of fire. And this one, so this is what a normal ovary looks like. I wanted to start with a normal ovary so that when we start looking at abnormal ovaries, it's easier to differentiate because we have seen what the normal one looks like. Before I show the abnormal ovaries, there's what we call estimation of risk of malignancy. There are different ways that have been, excuse me, different methods have been proposed for estimation of risk of malignancy, but there's what we call the International Ovarian Tumor Analysis Group. These are rules for estimation of malignancy risk of an adnexal mass, both premenopausal and postmenopausal women. It has a very good sensitivity, 95%, specificity of 91%, positive likelihood ratio of 10.37 and a negative likelihood ratio of 0.06. And it looks at the characteristics that are usually suggestive of neoplasm. This is usually an ultrasound scan that is done, and this is what they look like. What would indicate malignancy would be an irregular solid tumor, multilocular and irregular masses more than 10 centimeters in diameter, presence of septa that are 2 to 3 centimeters thick, presence of at least 3 papillary projections, increased vascularization, and evidence of ascites or peritoneal masses. So this is the most, it's widely studied, and it's also widely used as the International Ovarian Tumor Analysis Group. And then there's also what we call the risk of malignancy index. This is also quite common. There are the risk of malignancy index is 1, 2, 3, and 4, but number 1 is what is most validated and is what is mainly used. It has a lower sensitivity compared to the International Ovarian Tumor Analysis Group. The sensitivity is 78%, specificity of 87%. And for each the parameters it looks at is ultrasound scan, menopausal status, and CA125. So it's a product of ultrasound, menopausal status, and CA125. Based on ultrasound, of course, what is looked out for is multilocular cysts, solid areas, metastases, ascites, and bilateral lesions. And then for menopausal status, it's either premenopausal or postmenopausal. And then for the CA125, it is just the value that is measured in units per meal. So it just gets the product, and a score more than 200 is usually indicative of malignancy. So we're coming back to the abnormal. So this slide is looking at the international, the first one that I talked about, International Ovarian Tumor Analysis Group. Now, the column on the left is what would indicate malignancy, and then the column on the right is what a mass that is not cancerous would look like. So if we start with the mass that's not cancerous, the one on the right, it could be a unilocular cyst, any size, and you see this is what it looks like. This is not a cancerous mass. If the solid components present, they should be less than 7 millimeters in diameter, but ideally we should not see any solid component. And this is showing that presence of acoustic shadowing, all these are benign cysts, a smooth multilocular tumor with largest diameter less than 10 centimeters. And this is what we can see here, and no flow on Doppler. So you can see that this entire mass, there's no blood flow that is through the mass. So this particular column on the right is looking benign. So when we come to this that would indicate malignancy, we are looking at irregular solid tumors. You can see this is a solid tumor, quite irregular. Presence of ascites, which is basically free fluid within the abdomen, at least 4 papillary structures, which we can see here. Irregular multilocular solid tumor with largest diameter over 10 centimeters, which we can see here, and very strong color flow. It may not be very visible on this picture, but at least for malignant lesions, they usually have very strong flow on color Doppler. This particular slide, we will not go into the details of it. It's showing the characteristics, ultrasound characteristics of each of the masses that we have talked about in the previous slide. I have hinted on some of this in the previous slide, so I will not go into the details of these. This particular slide is showing the differentials for ovarian masses. For this, I'll basically say that benign ovarian masses in premenopausal women. Keeping in mind what the normal ovary looks like, this is the first row at the top shows what a typical hemorrhagic cyst would look like. Then the second row shows what a dermoid cyst would look like, showing, of course, different angles. Endometrioma is what is present on this. Basically, this is what it would look like, ground glass appearance. The simple paravarian cysts, now these are non-ovarian, like these are the differentials. This is what they would look like. The typical peritoneal inclusion cyst, this is what they would look like. And then the typical hydrosalpinx would also look like that. So this is basically for, it's very important as medical personnel to learn to interpret these images in instances when we do not have, at least you are able the normal of life. If you see something that's not normal, you'll be able, at least now like endometrioma, you'll be able to see that this is not a normal ovary. So we have also what we call a CT scan and MRI. However, it has been noted that there is no need for further imaging beyond transvaginal scan in the presence of benign lesions, especially because the ultrasound scan is able to characterize the mass in detail, and then it's also able to give you the estimate for you the risk of malignancy. So most of the time, it may not be beneficial to proceed to a CT scan. They do not improve the sensitivity or specificity obtained by a scan. However, they may have a role in the evaluation of more complex disease. And then in pregnancy, MRI may be more accurate in detection of the origin of masses compared to ultrasound scan. The accuracy for MRI in pregnancy is 100% versus 71% for ultrasound scan. So we move on to the management. The management takes into consideration various things, whether the patient has symptoms, the age of the patient, our fertility desires, presence of comorbidities, underlying pathology, the size of the lesion, and what we talked about, estimated risk of malignancy. So this particular table is specific for the non-gravid or the women who are not pregnant. And here it is stratified, or the description is based on the size. So simple ovarian cyst, usually unilocular, smooth ball on a point, as we've seen in the previous slide. If it is less than 5 centimeters in diameter, most likely it is a functional cyst, maybe it's a follicular cyst. There's no need for further follow-up. Then simple ovarian cysts that are between 5 and 7 centimeters may have 3 to 4 monthly reviews, because these are most likely also resolve, majority of them resolve. And then the simple ovarian cysts, usually further imaging may be warranted and surgical intervention. However, for persistent simple are probably increasing in size, usually surgical intervention is warranted. Now, this is basically summarizing what we've talked about as ovarian cysts or simple ovarian cysts in premenopausal women. And here I'll just focus on this other side, the left column, which is looking at the premenopausal. So it's simply stating what I've already stated in the previous slide: less than 5 centimeters asymptomatic, no further action, 5 to 7 centimeters. You repeat ultrasound in 3 to 4 months. If it decreases in size, no further action required. However, if it is increasing in size, and that's when your surgical intervention may be warranted. And then for cysts that are more than 7 centimeters, symptomatic or complex in nature, usually referral to a gynecologist who will definitely intervene. There are other parameters that are looked at in the management of ovarian masses. There's the role of contraceptives. It has been found that contraceptives do not promote resolution of functional ovarian cysts. And then there's also what we call aspiration of ovarian cysts, where you simply aspirate without really doing a cystectomy. This is usually not recommended, and it's associated with high recurrence rate. When it comes to the versus laparotomy, laparoscopy is preferred. It has multiple advantages: lost postoperative mobility, shorter recovery time. However, there are large masses where laparotomy may be the preferred mode or surgical approach. And then operectomy versus cystectomy. Here, cystectomy, I would say, is the operation of choice in premenopausal women. Which is because these are women who are still in their reproductive years, etc. So unilateral operectomy or salpingoperectomy, this means removing the ovary and fallopian tubes plus ovary on one side, is or may be indicated when ovarian tissue after cystectomy cannot be preserved. So that is when the ovarian tissue left is less than 3 square centimeters. There it means that the ovarian tissue cannot be preserved, and there you may go ahead to do the unilateral operectomy, salpingoperectomy of the affected ovary. And it's very important to counsel these patients before you actually go in for surgery about the possibility of operectomy. It's very important to discuss the diagnosis, stating that for some particular masses may be bilateral, for example, the mucinous tumors, the teratomas. Some of them may be bilateral, so that at least they know that. And then it's also important to counsel about the possibility of oophorectomy in case the ovarian tissue that is remaining after cystectomy cannot be preserved. It's very important, at least for someone, to go through all these details before surgery. So in pregnancy, this slide is a little crowded. You don't have to read through it, but I'll just summarize it and say that previously it was recommended that if you find a pregnant woman with a mass, probably an adnexomas or an ovarian mass, it is important do an elective surgery for these women in the second trimester or third trimester. And the reasons for this are malignancy and preventing complications such as torsion, hemorrhage, rupture, and obstruction. So now, if we dissect that statement, I would start by saying that majority of ovarian masses in pregnancy, they spontaneously progress. I mean, sort in size as the pregnancy. So, for example, we have looked at the corpus luteum cyst. We say it progresses by the 12th to 14th week. We have looked at what the majority of the cysts in pregnancy would resolve. So it's very important not to rush. And that is why the second trimester was suggested probably just at 16 weeks, because it resolves or reduced in size. Because the luteomas and the luteomas management dilemma because they are solid, and then we know that solid tumors are malignant. So that is one of the dilemmas with a luteoma. Now, one of the reasons exclude malignancy. A lot of studies have been done about malignancy, ovarian masses, malignant ovarian masses in pregnancy, and the evidence is quite low, less than 6%. And it has been shown that majority of the malignant ovarian masses in pregnancy are of the low of course followed by the epithelial ovarian tumors and tumors. Most of these in pregnancy, most of the time they are confined to the ovary and they are stage 1. And because they have epithelial nature, it has been found that during much may not add much benefit to the lady or to the patient. So that is the issue about malignancy. However, for masses that are rapidly increasing in size, showing presence of ascites, then these ones are surely showing, these are clear signs of malignancy, and it's definitely very important to intervene. One of the other reasons for proposing surgery was to prevent torsion. But then studies have shown that the rate of torsion is 1 to 7%. And so it has torsion is most common in the first trimester when the uterine volume is quite small. But as the uterine volume keeps increasing in the second and third trimester, it reduces the risk of torsion because the area or surface area keeps reducing. So the incidence of torsion is also quite low. And then the other complications that were fearing probably cyst rupture or obstructed labor are also not that common. So in summary, for management of the benign masses in a pregnant woman is that expectant management of an asymptomatic mass is recommended unless the mass is showing signs of malignancy or rapid increase in size, presence of ascites, or that is basically that's basically the summary. Distant management is preferred unless signs of malignancy or unless any of these complications definitely occur, and that's where torsion or cyst rupture, which are quite rare. So in case surgery is to happen in a pregnant woman, the timing is the second time, that best timing is the second trimester. Laparoscopy is still preferred over laparotomy. However, for laparoscopy, the patient is placed in the lateral decubitus position after the first trimester, and the fourth placement is placed with respect to the uterine side. The insufflation pressures the insufflation pressures are kept to less than 12 to 15 millimeters mercury, this will not affect the baby, I mean the fetus, as long as the insufflation pressures are kept less than that. It's very important to keep monitoring the fetal health and also so all pregnant women, mechanical and chemical thromboprophylaxis is very important. This is basically a summary of management of adnexomatous in pregnant women. First, in case she comes in with symptoms of torsion or rupture, it is automatically surgery. But I would say most of them are asymptomatic, and most of the time these masses are incidental or coincidental findings when someone is coming for an obstetric scan. And so this is basically what I've basically described in the previous slide. If they are basically benign features, you simply watch and wait. If it's an indeterminate mass, if it's in the first trimester, you wait until 16 weeks and see if it will persist. If it persists and it's with benign features, you watch and wait. However, if it has malignant features, you proceed to MRI and surgery. If it's in the second trimester, it means that it's definitely may not be one of the Cooper's lutein cysts, and so here you may proceed with the MRI or the surgery, and so the same with the third trimester. Yeah, thank you for listening.
Thank you, Dr. Carol. Back to Dr. Kizarek, take over. Okay, doctor, let me solve that.
Okay, so thank you, Dr. Carol, for the very informative presentation. Some bits were not clear because of your network, and some members were raising their hands, but I believe we have all learned something and we'll be able to manage our patients better. At this juncture, allow me to give you some of the questions that are in the chat. And then whoever has a question and can raise your hand, the host will unmute you and you'll be able to air out your question directly. Let me first read out the questions in the chat. The first question, Teresa at Haire was just thanking you. Mukembo was thanking you. Many people were thanking you. There is one who was asking, I don't know if he has gone. Please unmute. I mean mute, not unmute. There was someone who had asked about I had written it somewhere. Somehow it has disappeared. Tadeo, the first questions, please. I'm not able to see on my phone, but someone had asked about management of adenoid cysts in pregnancy. But otherwise, majority of the people are appreciating you for the wonderful presentation and are requesting for what? Requesting for the PowerPoint presentation. Let me see the new message. Someone has asked Sebo Andrew, is there a role of Onilox? I think he meant Onilox, in management of benign cysts. Then Kasule Musa is asking, it has disappeared. Any role of methotrexate in management of ovarian cysts? She didn't specify whether they are benign or malignant. Then Christopher Wako was saying, Dr. Carol, insulin resistance is a feature in polycystic ovarian syndrome. Is it a case for malignant ovarian masses? Also, how do we go about a medical dilemma for a malignant ovarian tumor? who wishes to terminate the pregnancy before 28. That ethical dilemma is there. I think you can take on those ones as we wait for people to ask direct.
Okay. Thank you very much for that question. We have read quite a number of them at our goal. I'm trying to see which one I'm going to answer first. Maybe Dr. Susan, is it possible to ask them one by one and I answer? Because
Okay.
I think you've in a row. And I think
asked many questions. Okay, we
Mm.
start with Christopher. He said, Dr. Carol, insulin resistance is a feature in polycystic ovarian syndrome. Is it a case for malignant ovarian masses? And then the second question, how do we go about a medical dilemma for a malignant ovarian tumor in a woman who wishes to terminate the pregnancy before 28 weeks?
Okay. Thank you, Christopher, for that question. You've asked how do we go about a medical dilemma of a malignant ovarian tumor who wishes to terminate the pregnancy before 28 weeks, that is in Uganda. I would say that it would depend on the type of, it would depend on various things. Did this woman present with, was this diagnosis of malignancy already known before she got pregnant, or it was an incidental finding after she has gotten pregnant? Because those are two different things. If she already had got pregnant, that would change everything. However, if it was an incident during pregnancy and you have not, I would say it's a difficult one to answer, but one should be eligible for surgery in case it was diagnosed during pregnancy. And of course, if it's an ovarian tumor, hysterectomy would be done. Now, about the wishing to terminate a pregnancy, it depends on the literature, because I would say it depends on the tumor it was, but I would not really say that pregnancy should be terminated. Basically, depends on various factors. But just to remind us, or to remind us that most of the malignancies are seen of the low grade epithelial tumors, which most of the time they are still, I would say, in this case, it should not be that important to terminate the pregnancy. Insulin resistance is a feature in people. Is it a case for malignant ovarian? Depends on which type of malignancy it is. Thank you.
Okay. Dr. Carol. Dr. Carol, there's a lot of background noise. But then I also needed to supplement something on this. I wanted to supplement something on Christopher's question. I think there will be no medical dilemma or ethical dilemma. Yes, medical termination of pregnancy is allowed if the pregnancy puts the mother at risk, is progressing as evidenced by growth ascites, rapid growth of the tumor. There will be no ethical dilemma, I think. But yeah, you have to put in consideration all those things. If the woman wants the pregnancy out and is forcing a worsening clinical picture, then there will be nothing against the medical personnel. You'll be allowed to do medical termination of pregnancy. I hope we have been able to answer your question. Then Kasule Musa asked, is there a role of methotrexate in ovarian cysts? He didn't specify whether malignant or benign, but I think here he's talking about the benign.
For the benign, I would say there is no role of methotrexate.
Yes, there is no role. And then another person, Seboa Andrew, asked, is there a role of Onilox in management of ovarian tumors? I think he's talking about benign.
Did you say Onilox?
Is there a role? He has put Onflox, but I think he meant Onlox or Ofloxoxas. The name has also disappeared. Yeah, that one that we are used to, Onlox.
Okay,
Is there a role?
assume. I would assume that this one is basically asking about the role of antibiotics in the
Yeah, someone
management.
else had also asked.
Yes. So the antibiotics will depend on what type of benign ovarian mass that you have found. For example, we have looked at the different differentials. It would have no role in endometrioma, it would have no role in adenoma. It will not even have a role in follicular cysts. So I would say in the majority of the benign ovarian cysts, directly speaking, antibiotics may not have a role. However, in case of a pelvic infection, PID, antibiotics do have a role in management of benign ovarian, or basically PID, pelvic infection.
Okay, I hope Moses, Nasim, and Sebo Andrew, you've also been answered. And then Nachiwala Smaya asked, what is the cause of reoccurrence of ovarian cysts? I have had 3 surgeries. That is Nachiwala Smaya. From a personal experience, she said she has had 3 surgeries for ovarian cysts. What is the cause of occurrences?
Okay. Most of the time when surgery is done for ovarian cysts, the cyst wall, that is. Okay. So most of the time when we do surgery for ovarian cysts, the cyst wall that has been removed is taken for cystectomy. Definitely, reoccurrence may be due to multiple things. One of the reasons for reoccurrence that we have seen in this presentation is respiration. In case we just aspirate and we are not able to completely remove the cyst wall, then the chances of recurrence are high. Or if we do not totally remove, basically the cyst wall, I would say that's one of the main causes of recurrence.
She has also added that she has had 3 surgeries and now she has another cyst measuring 6.9 by 5.8. I think you need to be evaluated by a gynecologist or a gyne-oncologist before you go in for your 4th surgery, please. There are many. Members, I'm requesting for 5 more minutes to answer these questions, to allow the presenter to answer the remaining 13 questions. Veronica Navide says, on day 10 of menstrual cycle, how is the dominant follicular cyst supposed to look like? on ultrasound scan? And if possible, what would be the diameter? I think this one
Okay,
depends.
thank you.
But anyway, Carol, over to you.
Yeah, thank you for that question. The dominant follicle, if you're asking about the ultrasound features, it's basically unilateral, smooth walled, anechoic cyst, unilocular. The diameter, I would say, at around on around the 10th day, the diameter should be at least above 10 millimeters. I would put it
1.8.
Yeah, I would put it between maybe 10 and 15 millimeters on the skin.
Okay, so it should be clear or black with no complex masses in the center. So then Peter is requesting you give him a copy of the sonography atlas used by you. I don't know, I think you can inbox her directly and share your email address. Then Veronica is asking, how would you differentiate a pathological follicular cyst from a dominant cyst? I think those ones we really, when you get the presentation, she was elaborate enough. But yes, Carol, you can throw some more light for Veronica.
Okay,
Differentiating a pathological cyst.
So I would say that the a cyst that is not pathological is usually smooth walled, unilocular, and echoic. Most of the time unilateral. And then it has no flow on color Doppler, I would say. But then for a pathological cyst, it's usually multilocular, it may have papillary projections, and it does have color flow through the mass or through the both. Those are the pathological features.
Okay. The same Veronica is asking you, how would you diagnose polycystic ovarian syndrome on scan? I think we looked at the pictures there.
With polycystic ovarian syndrome, the ovarian volume is usually enlarged more than 10 cc, with multiple peripheral multiple peripheral follicles, probably less than 10. Yes, each measuring. Yeah, they are usually quite small. They look like a mucus.
And anechoic.
Yeah.
Okay. Veronica, we have answered you. You have said your PCOS question. I hope you have heard. They're usually peripheral follicular cysts, small and anechoic. They don't have any locus. It's clear fluid or black, nothing white inside. Then what are the signs of malignancy on ultrasound? That one I think she has elaborated many on countless occasions, but maybe you can summarize for Charissima, Mariam.
So on ultrasound, yes, the signs of ultrasound scan is a mass that is usually it's multiloculated. It may be solid, or it may have solid areas. It has papillary projections, and of course, there's color flow on Doppler. But then it may also coexist with other things. For example, other features like presence of ascites or a mass that is rapidly increasing in size. All those are signs of malignancy.
Okay. Bomwaka Agustin is asking, is there no oral medication for benign ovarian cysts?
Oral medication for benign ovarian, it depends on the diagnosis. It depends on what the diagnosis is. I think the main thing is the main thing that we have to do is make the diagnosis based on ultrasound scan, decide whether it's benign or not. And then certain benign conditions, let's say dermoid cyst, there's no oral medicine that is going to be helpful to such a diagnosis.
Okay. Then Deo Deo T is asking, for large cysts in a pregnant mother, can't aspiration of the cyst be advantageous to the fetus rather than open surgery?
First of all, if it is, it depends on the size of the cyst. But one, I would say if it is asymptomatic, most of the time we may not intervene. And most of the times we intervene because the patient is maybe symptomatic, or maybe because there could be a complication. However, restoration of cyst, whether in pregnancy or not in pregnancy, pose a risk of recurrence. And then also aspiration, yes, aspiration, when you're not sure whether it is malignant or benign, will actually be more detrimental
To the patient.
than actually training.
Was rapid progression. Okay. Aisha Ahmed is asking, how are oral contraceptives use, combined oral contraceptive use, linked to development of benign ovarian masses? Is there a hope for a pregnancy after oophorectomy or cystectomy? I think this one was answered.
I think with the combined oral contraceptive, I would say that there is no role. They have no role in the management. Or it used to be suggested that they may reduce on the size of the function of ovarian cysts, but they have no role. However, COCs are said to be protective against ovarian cancer. And then you're asking if someone can conceive after oophorectomy. It's a unilateral oophorectomy because you have one ovary that is viable. Yes, you can conceive. Me with cystectomy.
Okay.
Conceive.
Okay, so then I think this one is our last one. Shamina Mnava is asking, can you please talk about hemorrhagic cysts? I think you never talked about complex cysts. I also don't remember hearing them.
Hemorrhagic cysts, I'll just give an example of maybe the Lutein cyst. Usually, this is a cyst that is formed after the ovum has been released. And so after the ovum has been released, vascularization or new vascularization, formation of new blood vessels may form within that cyst or the corpus luteum cyst. And sometimes these vessels that have been formed could rupture. And when they rupture, it means that there is bleeding into the cyst. And when there's bleeding into the cyst, it is what is called a hemorrhagic cyst.
Okay, thank you, Dr. Carol. Then the last one, or second last, Kamsime Claire is asking, combined oral contraceptives are usually given in management of polycystic ovarian syndrome. Is that right or wrong?
POCs are part of the management, at least for PCOS. There are various drugs or modes that can be used, but at least POCs is one of them. So it is right.
They are not used in isolation. They are combined with other hormones. Then Wako, Christopher, I think this is our last question, Dr. Carol. What is the likelihood of metastasis? And does this have an effect on the management strategy? I think that question is incomplete. But is the question clear?
No, the question is not clear. What is the likelihood for metastasis?
And does this have an effect? Maybe
I
Wako,
think
you
it
can. You can ask your question direct, but before you ask, let's take on Saidali Abdrahim. Impact of imaging advances. What with advancements in imaging technology, how has the diagnosis and characterization of benign ovarian masses evolved? Are there specific imaging modalities that have proven particularly valuable in your experience?
With the advancement in imaging technology, I would say that it has been noted that the ultrasound scan is the first line and gold standard in the diagnosis characterization of benign ovarian masses. But an ultrasound scan done well is far better than a CT scan. Actually, there's no need because it gives you so much. And actually, it is now, we use it as a first line for multiple conditions. For example, endometriosis. In the past, we used to say endometriosis, we have to go for MRI and what, but now we are able to do transvaginal ultrasound scan with such detail that they are able to
Yes.
all the lesions. Yes. So I would say that maybe the advancement, the ultrasound scan has gained more credibility in the diagnosis of this.
Okay, I hope it is clear to everyone. Ultrasound scans are able to pick benign ovarian tumors as early as possible. The preferred route is the endovaginal or transvaginal route. Then Shamina wants you to support her understand the management of hemorrhagic cysts and how urgent should it be. And the last one, I think, hemorrhagic cysts management.
Yes, with the hemorrhagic, okay. With the hemorrhagic cyst, it's more of conservative management. It's a pain management as long as analgesia is given. It is conservative management. These cysts usually resolve. They resolve over 3 cycles, 2 to 3 cycles.
That is 3 menstrual cycles. Then what are the recommended follow-up protocols for premenopausal women with benign ovarian masses?
This one is what I had discussed earlier. Definitely depending on the size of the mass. In case it is a simple ovarian cyst, less than 5 centimeters, no follow-up. If it's between 5 to 7, it can be followed up every 3 to 4 months or every year. But then if it is more than 7 centimeters, then further evaluation is warranted. Of course, if the cyst is persistent or increasing in size, that one must be immediately, intervention must take place. If there are any features of malignancy, that particular miss should be addressed. That I would say. Then specifically to teratomas, with teratomas, there's no literature that particularly states the size at which a teratoma should be removed. Teratomas grow in size every year. They have a very slow growth rate, and generally it is still postulated to state that if a teratoma is 5 to 6 centimeters, it should be removed surgically. But with teratomas in particular size, that no literature which states a particular size above which a teratoma should either be removed, it should be conserved. I hope that's clear.
Yeah, it is loud and clear. I think, members, she has done us well. On my own behalf and entire BHF family, I would like to appreciate you, Dr. Carolyne, for the very informative, well-articulated and well-researched discussion that you have given us. It has been very enriching, and I believe many people have picked a leaf. And to my friend who has had recurrent surgeries, please walk into a gyne office, be evaluated before you have a fourth surgery. And with the information that you have got from here, I think you'll be able to also think about what you have and how you should be managed better. Well discussed with your gynecologist. At this juncture, allow me to hand over to Benjamin to give us our closing remarks and also hand over the certificate of appreciation to Dr. Carolyne Oleo. Thank you, members, for keeping it at BHF up to this time and for giving us extra minutes.
Thank you,
Over to
Dr.
you,
Susan, and
Benjamin.
thank you, Dr. Carol, for this wonderful presentation. It has been enriching, it's been learning. And I want to invite our CEO, Mr. Moses Changwa, to close this session and also invite members to Dr. Speciosa's home this Sunday. Mr. Moses Changwa, you're welcome to give the closing remarks.
Hey, thank you so much, Benjamin, and thank you so much, Dr. Susan and Dr. Carol, and all our esteemed participants. Thank you for always joining BHF. We are so glad that every Friday we are able to communicate and interact, share. We would like to invite you to visit our website. There's a lot to learn. Visit our Twitter handle, visit our social media pages. BHF communicates every hour. There's a lot to learn. And we also want to invite you to join us as members by registering and subscribing so that we are able to run these activities like these CMEs and any other activities that we run. We would like to also encourage you members, some of you who are working with districts, support the Child Health Integrated Days. Most of our districts need your help, need your support. So whoever has an opportunity to support in mobilizing, support in clarifying a few things here and there, please join hands. We would like to invite you and we'd like you to support our health workers, the grassroots frontline health workers who are doing this job, so that they're able to integrate these activities. And they don't forget our immunization of our girls, 10-year-old, the HPV. As a Busoga Health Forum, we are moving towards the end of the year, and we usually have a number of activities. We are glad to alert you that our patron has invited us for an engagement, sharing, and learning. So at Dundu in Mkono, shall be having a Sunday to spend with her and to learn about wellness, health and wellness, and again to show us a few things that we need to learn from elders. So everyone is welcome. Just inbox us so that we can confirm your attendance and plan for your visit. And at the visit, there is a lot for you: BHF calendars, BHF notebooks, BHF t-shirts, everything will be available. So please join us. And I would like to take this opportunity to thank Dr. Carolyne Oleo for sparing the time, engaging and doing the research, making this presentation that has made a lot of contribution to our health workers in the country to learn about this important topic today. So for that matter, Busoga Health Forum awards you this certificate, which you will receive in a soft copy, but Benjamin can always arrange to get you the hard copy. And we thank you so much for supporting BHF and contributing to knowledge sharing in the region. At the same time, like to thank Dr. Susan for always supporting and being there for the forum from the inception. You have been there for us, and thanks for moderating this important session. And would like to say God bless you so much so that you continue guiding the nation.
Thank you.
Yeah, we want to say that PHF has a lot. Just keep on our pages, and you will enjoy the services that committed members of Soga Health Forum are providing through different services. Thank you so much, and say God bless you so much. Have a good.
Thank you so much.